Good afternoon, and thank you for joining us for today's NILE webinar. This is Brianne Van Dyne, the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple of housekeeping items. First, if we should become disconnected for any reason, please call right back and we will continue, or log back in if you're listening from your computer today. Second, please locate the chat box on the bottom left-hand corner of your screen. If you have any questions, type them in the chat box and we will address those questions throughout and at the end of the presentation. Lastly, if you have requested nursing, pharmacy, or dental hygiene continuing education credits for today's webinar, please make sure that you complete the survey, which will pop up on your screen when the webinar is ended, or in the post-webinar email. All CEUs will be emailed out within the end of the week. Before we begin, I'd like to provide a little disclaimer. Immunize Nevada's NILE webinars are made possible by the generosity of speakers who donate their time and expertise to benefit the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd like to now turn it over to our speaker, Lancet Van Gilder, who works as a clinician in private practice, in the corporate world as a professional educator, and as a public health dental hygienist, along with being an internationally recognized continuing education speaker. Lancet graduated with her dental hygiene degree from the University of South Dakota in 1995 and has been actively involved in dental hygiene education, leadership, and advocacy on the local, state, and national level for the last 23 years. Thanks for joining us today, Lancet.
Thank you so much. Hi, everyone. I'm Lancet. I'm excited to spend a little bit of time with you today as we discuss the very important role that dental professionals have in oral cancer education, screening, and now, and more importantly, hopefully, oral cancer prevention. We know that prevention, education, and early diagnosis are key with any type of cancer, and oral cancer is no exception. 1 American dies every hour in the United States from oral cancer. This course will explore oral cancer kind of stats and statistics and is intended to educate the entire medical and dental team on the crucial role that each one of us can play in the cancer prevention process. So before we get started, let's kind of see where you guys are at. What do you think? What risk factor do you think contributes to the most amount of oral and oropharyngeal cancers? This is where you get to participate in this whole process. We have a few choices. All of these are documented risk factors, but which one of these do you think contributes to the most amount of newly diagnosed cases? We have genetics, we have viral, we have bacterial, we have heavy smoking, we have alcohol and tobacco use combined, marijuana use, poor diet, or chronic irritation and inflammation. We're going to give you a few seconds so you can go ahead and participate in our first poll. And I think as soon as Brianne collects all the results, we'll all be able to see the results on the screen.
And Lancet, if you click on the, well, actually, I can just read them off to you right now. It looks like we've had quite a few users that have responded. It looks like 8.3% of our users think that it is the genetics play a role. 16.7% believe that viral plays a role, or viruses. Same amount for heavy smoking. We have 41.7% that think that it's alcohol and tobacco use combined, and then 16.7% who believe that it's due to chronic irritation and inflammation.
Okay, awesome. Thank you guys so much for participating. It's really fun to be on my end, to know that you're there and kind of what you're thinking. This is quite surprising, actually. 70% of new oropharyngeal and oral cancers diagnosed are actually due to viral. Viruses right now is considered the #1 risk factor for oral and oropharyngeal cancers. We know we have low-risk strains of HPV, which traditionally present as mouthwarts. That doesn't typically lead to oral and oropharyngeal cancer. But we have high-risk strains of HPV, like specifically HPV-16, that is very, very highly directly related to oral pharyngeal cancers. So we do know that smoking and alcohol use combined is right there next on the list, so still considered primary risk factors. Genetics account for only about 10% of all oral and oropharyngeal cancers. So that's the whole point of why we're talking today. This is new information, new science that many of us dental professionals were not taught in school. This is new science that's emerging just recently in the last few years as we've seen such a high influx of oral and oropharyngeal cancers. So thanks for participating. I also really want to thank Immunize Nevada for this great opportunity, a very progressive way of thinking to, really bridge the medical and dental worlds together. We know that it's more important than ever. Dental disease and medical health, we know, are directly interrelated. Vulnerable populations experience disease and poor health outcomes at a higher rate. More outreach is needed because the gaps in healthcare are getting bigger, not smaller. We have emerging research nearly on a monthly basis that are telling us, that our populations are not healthy, and we know more and more and more diseases are specifically linked to the health of our mouth. So with the burden of diseases and cancers in our society, now more than ever, we know that prevention and education efforts are needed in all settings. Why else is medical dental integration important? We know that oral health access is enhanced when provided in primary care settings. We are seeing a big influx of nurses and pediatricians delivering fluoride at well visit checks for children to ensure they're getting preventive care. We know that medical care access can be enhanced when it's provided in a dental setting. And we know we need a broader reach for our high-risk patients, and early detection can save lives. There are 11 different bacteria that live in the mouth and about 6 different viruses and fungi that live in the mouth that have been linked directly to oral systemic diseases like heart disease, stroke, diabetes, pancreatic and kidney cancer, Alzheimer's disease, and even head and neck cancers. Many additional screening tools are being implemented into the dental setting, specifically things like chairside A1C testing, HIV rapid testing, blood pressure checks, annual height, weight, and BMI measurements, and airway assessments. Dental professionals like dental hygienists, dental therapists, and dentists can play a key role in addressing many public health problems. By offering education and screenings in the oral health setting, we can raise awareness about the many oral systemic conditions. In fact, the dental professional may be the only healthcare provider that a patient may have. Chairside A1C testing could have a significant positive impact on health, since 30% of people who have diabetes are undiagnosed. There's a bidirectional link between oral health and diabetes. HIV is still considered a public health concern, and again, many go undiagnosed in early stages. There's a significant body of evidence between oral health and obesity. We know obesity rates are rising, especially among our youth. And airway-centered disorders are structural and physiological conditions of the mouth, the jaw, and the nasal passages, the tongue, and the throat that can lead to breathing issues as well as chronic health problems. So dental professionals can play a greater role in HPV vaccination, and we can add this to the list of those other things. What we can do in the dental world is we can educate our patients about the gap years. There is a significant gap between when somebody may actually become infected with the HPV virus and when they actually may develop cancer. It could be anywhere from 20, 30 to 40 years later. And we can warn our patients that typically there is no precancerous changes or warning signs for oral and oropharyngeal cancers, and we can address the effectiveness. It's expected that vaccination can prevent maybe up to 90% of oropharyngeal cancers caused by the HPV. And vaccination is extremely effective at preventing the types of HPV that specifically cause oropharyngeal cancer. The American Dental Association has taken a pretty proactive role in promoting talking about HPV and vaccinations in the dental office in 2017, 2018, and 2019. The American Dental Association also now has produced a brochure that can be distributed in dental offices that specifically talks about oral health and the HPV vaccination, and really talks about making a strong recommendation for the vaccination. And something very exciting happened this summer in Oregon. Oregon became the first state to adopt regulations to allow dentists to administer all vaccinations in the dental office. This had broad medical and dental support to help bridge medical and dental collaboration. It also is intended to help meet the goal for 70% of Oregon adults to receive annual flu shots. It helps students receive vaccinations needed to attend school, and is intended to help promote the very, very important HPV vaccination. So dental schools in Oregon will start teaching vaccinations in 2020. The Oregon Dental Association is already developing courses to help teach practicing dentists how to administer vaccinations. And many other states, including Nevada, are looking at how dentists, dental hygienists, and dental therapists may also help. Proper vaccine administration is critical to ensure that vaccination is safe and effective, and the CDC recommends that all healthcare personnel who administer vaccines receive comprehensive, competency-based training on vaccine administration and policies before administering vaccines. And comprehensive skills-based training should be integrated into educational programs and offered to those already practicing. Oral cancer kills 1 American every hour, every day. It's important to point out that as I go through today's presentation, I'm going to be talking about oral cancer as a very broad category. But oral cancer can be in the front of the mouth, it can be in the back of the mouth, it can be down the throat. When we specifically talk about oral cancer in the back of the mouth and down the throat, the proper term for that is oropharyngeal cancer. So we kind of use oral cancer as a very broad term, but it is very important to know that moving forward, a lot of the stats that we're talking about are specifically related to oropharyngeal cancer, the back of the throat, back of the mouth, down the throat, maybe even into the neck. And 70% of those cancers can be directly related to the HPV virus. Oral cancer kills as many people as melanoma and is now more common than leukemia. We have about 53,000 new cases every single year in the United States, and it accounts for about 10,860 deaths per year. And the really sad statistic about oral and oropharyngeal cancer is 43% will not survive past 5 years of their diagnosis. We know that about 40 to 60% of the population has visited the dental office in the last year. However, only 15 to 25% of patients report having routine oral cancer screenings. So I know those of us that work in dentistry might be thinking, well, maybe they're getting screenings and they just don't know it, because I can say as a practicing clinician, many times I just do it as part of my routine. I'm not telling the patient what I'm doing. However, statistics show us that patients are accurately reporting. Only about 25% of dental hygienists report doing routine oral cancer screening, and only 14% of dentists report doing routine oral cancer screening. So what patients are reporting falls in line to self-reporting of practitioners as well. Some of the most current data that really just came out in the last week or two shows that this last year or two, there's been a really big focus on trying to get more information about oral cancer to dental professionals. However, even with enhanced education and webinars like this, still only 1 out of every 3 people who visit a dental office regularly are getting routine oral cancer screenings. So only a small amount of oral cancers are being detected in early stages. 73% of dentists and 33% of physicians report that they have received adequate training regarding oral cancer. We know that providers are less likely to provide services such as screening if they haven't been properly trained. This was a really interesting report called The State of Science. It came out in 2018. You can find it on the Oral Cancer Foundation website. Only 14% of dentists reported doing routine oral cancer screenings. 69% of dentists failed to recognize oral cancer. 15% mismanaged or delayed diagnosis. And the majority of dentists were unaware of high-risk behaviors. 64% were unaware of tobacco. 40% were unaware of their patients' alcohol use. Only 35% were asking their patients if they smoke, and even significantly less if they chew tobacco. And the public isn't all that educated either when it comes to oral cancer. They don't really understand the risk factors at all. When the public was surveyed, very few know that heavy drinking is a risk factor for oral cancer. However, they understand that it's bad for the liver. Tobacco, 2/3 of people surveyed were aware that it can contribute to heart disease, lung cancer, and emphysema, but many are unaware of the oral cancer risk. And the majority of the public does not know the early warning signs of mouth or lip cancer. And the public says that no, nobody in the dental office is really talking to us about HPV. So I'm going to jump forward here. This is your next poll for you guys. Here's a question for you. So we know that there has been a big increase in newly diagnosed oral and oropharyngeal cancers. But is it still kind of considered a rare cancer? True or false? We're talking about it today, and we think it's extremely important. It's really relevant. But is it rare, or do you think it's pretty common? True or false?
Lance said it looks like we're split right now, about 50-50. Oh, just went up false. We have almost 64% of our users think that that's false, and now 33 think that that's true.
Okay, awesome. Well, you guys are pretty smart. It's kind of, really both are kind of right. In general, though, we're going to go with false. It is the 8th leading cancer for men in the United States. What we're really concerned about is that HPV-associated oral cancer rates are skyrocketing. Unfortunately, with a lot of other cancers, the rates are going down, but with oral and oropharyngeal cancers, the rates are increasing every year. More people were diagnosed with mouth or throat cancer in 2017 than many other cancers, such as cervical cancer or stomach cancer. We know that mouth and throat cancers together rank 6th among cancers worldwide. So on a global level, it's actually pretty common. Oral and oropharyngeal cancer can affect men and women of all ages. However, men are 4 times more likely to develop oropharyngeal cancer, and the average age of diagnosis in the U.S. is about 62 years old. Oropharyngeal cancer is the most common type in men under the age of 40. Oral and oropharyngeal cancers are a global epidemic with about 640,000 cases each year. It's the 6th leading cancer in the world. In the U.S., it's the 8th leading cancer for men right now and the 13th leading cancer for women. Both men and women can get HPV infections. HPV infections can be transmitted through the skin-to-skin contact, or sexually transmitted. HPV infections are typically asymptomatic, and they clear the body within 2 years. 99% of all cases will actually clear the body within 2 years. However, 1% of cases, they stick around. They go dormant, and they lie in the body for about 20, 30, or 40 years, and then become reactivated and may contribute to oral and oropharyngeal cancer. Not all strains of HPV cause cancer. In fact, most do not. Most HPV infections go away and do not cause cancer. But the HPV-16 strain is most directly linked to oral and oropharyngeal cancers. Men are at more risk since HPV infections linger in the body for longer periods of time. There is no treatment for the virus, only some for the symptoms like warts or lesions. And for some reason, women's bodies seem to have the ability to clear the infection more efficiently. I know that this chart is hard to read, and it's actually kind of old, from 2003, 2004. But I just want to show you that, Nevada typically ranks pretty high among the nation, definitely in the top 15 as far as the number of cases diagnosed with oral and oropharyngeal cancer. So some interesting facts about oral cancer. Say you develop oral cancer, you get treated, and you are lucky enough to be in that, 60% that do survive more than 5 years. Your risk of developing a second cancer is 20 times higher. 75% of all oral cancers are directly related to lifestyle choices and totally preventable. 90% of oral cancers are squamous cell carcinomas, and the rates are going up, they're not going down. If carefully examined, someone who is newly diagnosed with oral or oropharyngeal cancer, a small portion will have another cancer in a nearby area, specifically maybe the voice box, the esophagus, or lungs. Some who are cured of oral or oropharyngeal cancer will develop another cancer later on in the lung, mouth, throat, or other nearby areas. People who go through treatment and are diagnosed will have to have follow-up care for the rest of their lives. They also need to be counseled on avoiding tobacco and alcohol, which increase the risk for second cancers. These are the types of cancers that our patients are most likely to develop 20 times higher risk if they do survive their treatment for their primary oral cancer. Lung cancer, cancer of the bile ducts and cervix, colon cancer, chronic myeloid leukemia, Hodgkin lymphoma, thyroid cancer, stomach cancer, pancreas cancer, rectal and anal cancer, and maybe even another type of oral cancer. Back in the olden days, meaning more than 5 years ago, these were kind of our classic 3 signs of oral cancer. And these are still true. However, the signs and symptoms now are a much broader range, and we'll go over that. But we used to tell people these are the things that you want to look for: a sore that doesn't go away, red or white patches, or persistent pain or tenderness when swallowing. Now, these are considered our primary kind of signs and symptoms and seem to be pretty common with oropharyngeal cancers. Loose teeth. I had a patient in just a couple weeks ago, a young man in his 30s, who was having trouble chewing. He noticed all of a sudden that 2 of his molars on the lower right side were a little loose. And sure enough, after a thorough examination, we found a tumor. He went in immediately that day for a biopsy, and he was diagnosed with oropharyngeal cancer at the age of 31. But his primary symptom was all of a sudden his teeth on the lower right felt loose. Very common one also is a change in voice. This is how a lot of celebrities have actually been diagnosed. And what the first symptom they noticed was a change in their voice. Swelling in the jaw, a sore throat, or feeling like something is stuck in the throat, that sensation that you have to clear your throat all the time. Trouble chewing or opening or closing the mouth, maybe even kind of a tight TMJ or jaw, sore that bleeds easily, red, white, or black patches, a sore that doesn't heal within 2 weeks, ear pain on one side, or a lump anywhere, especially in the neck, and unexplained numbness or tingling. So prevention is best, and early detection is key. We want to recommend that patients are looking at their mouth and their throat at home on a monthly basis. We want to make sure that people are having routine oral cancer screenings by a dental hygienist, a dental therapist, or a dentist. If somebody has high risk factors, we absolutely recommend more frequent screening, knowing that early detection and medical dental collaboration is key. The most common areas for oral and oropharyngeal cancer are highlighted in yellow: the very, very back of the throat, tonsils, and way down deeper where we can't even see, the sides of the tongue and the floor of the mouth. The floor of the mouth, the soft palate, the throat, and the sides of the tongue are the highest risk spots for oral and oropharyngeal cancer. Less risky sites include inside the cheeks and our lips, and the bottom of the list, where it is a little bit more rare, is the top of the tongue and the roof of the mouth. So the vast majority of new cancers being diagnosed are the oropharyngeal cancers. This is the back of the throat, the base of the tongue, down the tonsils, into the throat, under the jaw, and into the neck. This is specifically harmful because we know that when something is down here in this pharyngeal area, that most likely there is going to be lymph node involvement. The anterior, the front part of the mouth, if oral cancer does present here, it is typically not HPV related. That is more often related to tobacco and alcohol. The back, so the posterior part of the mouth, the base of the tongue, the back of the throat, and the tonsils, is most likely related to the HPV and is most likely squamous cell carcinoma. In a dental office, there are a few adjuncts that have been developed to help dental professionals in their screening process. We have tissue staining techniques. We can take a sample of the tissue using brushes. And then we also have new visually detecting devices that use wavelengths of light, including blue, amber, white, or violet. We also have a salivary diagnostic tool that is called Oropharyngeal HPV, where you can test for certain strains of HPV in saliva. None of these tests are definitive, where we can actually say that somebody, yes, has HPV or not. These are really intended to be used as adjunctive screening tools to kind of help you in your conversations with your patients, to help counsel your patients on risk factors, to help provide collaboration between medical and dental providers if somebody were to test positive, and then, of course, also kind of help with how often we want to maybe be screening and seeing our patients. The staining techniques are really specifically to help really determine maybe the extent of the lesion when a biopsy is being taken. This dye actually only stains abnormal tissues. So what might look like a small lesion visually, when the dye is placed, you might see that there's abnormal cells in quite a broad area, and that helps the practitioner know how much tissue may be to remove when they're doing the biopsy. This is one of the examples of the light frequency tools that's being used in dental offices. I use this all day long on my patients. This is to help detect abnormal cells below the tissue where we can't see. The whole goal of some of these adjuncts is knowing that there might be more serious things going on that we can't see with our eyes. So how do we use saliva? How do we stain the tissues? Or how do we look with different light visualization tools to help us really maybe evaluate tissues where we can't see? In my office, we have been able to actually pick up quite a few cases of oral cancer using the light tool that showed us some abnormalities. We were able to then refer to a specialist and get the patient seen sooner before a lesion ever manifested in the mouth that we could see with our eyes. So let's talk about risk factors. I will tell you, up until just a couple years ago, that yes, tobacco, alcohol, genetics, chronic irritation, those were always considered kind of our primary risk factors, but things have changed. We now know the new risk factors for oropharyngeal cancer specifically are viral, bacterial, fungal, and chronic inflammation. We've known forever, of course, that sun exposure, extensive radiation, tobacco, alcohol, poor diet, nutrition, and irritation were also contributing factors. This is a really great resource if you're looking for a booklet to, again, help with this medical dental collaboration regarding HPV. This HPV roundtable booklet talks about some other high-risk factors: chewing tobacco, heavy smoking being identified as a pack a day or more, chronic inflammation, anybody who has a weakened immune system. Current marijuana use is actually a documented risk factor for oropharyngeal cancer. And that would be smoking, not edibles. Having 16 or more sex partners in a lifetime, or men with 2 or more same-sex partners. The reason I really like this booklet is it does have an action plan with 5 kind of key sections that can really help dental professionals incorporate a nice, robust kind of HPV program for their offices. And it really encourages dental professionals to understand the unique role that they play in cancer prevention and actually to actively practice cancer prevention, like pamphlets, medical history screenings, providing vaccinations, collaborating with the medical team, and engaging the team, the whole team. We also know that bacteria, though, is a new risk factor for oral cancer. This is very, very concerning. Right now, it's estimated that at least half the population has gum disease, periodontal disease. That's 1 out of every 2 people. One of the primary pathogens that's involved with gum disease is called P. gingivalis. That's what we call it for short because it has a very long name. But in patients who've been diagnosed with esophageal squamous cell carcinoma, like in their throat, 61% of the time, P. gingivalis was inside of the tumor cells, but also P. gingivalis extended to about 12% of all the surrounding tissues of the cancerous cells. So we are considering now the presence of P. gingivalis, one of the primary germs that cause gum disease, to actually be considered a risk factor for throat cancer. P. gingivalis can be present in gums that bleed when people brush or floss. If the gums are red or that they're swollen, P. gingivalis is usually there. If somebody has periodontal disease and have actually lost some of the bone that's holding in their teeth, P. gingivalis is always present. So the presence of P. gingivalis, which is a bacteria that starts in the mouth, it doesn't start anywhere else, is being linked to almost everything bad in the body, but specifically throat cancer. Interesting thing as well that that pathogen causes bone loss, causes pocketing around the teeth, and if you have 1 millimeter of bone loss, you are 5 times more likely to get tongue cancer, and your risk raises 5 times with each millimeter of bone loss. So the World Health Organization lists these strategies for cancer prevention: a healthy body, healthy mouth. Avoiding tobacco, this is still considered a primary risk factor, as well as secondhand smoke and secondhand vapor. Limiting alcohol, 1 per day for women, 2 per day for men. Eating healthy, 2.5 cups of fruits and veggies a day. Vitamins, minerals, antioxidants in a plant-based diet. Knowing that sugar causes cancer cells to grow. Maintaining a healthy weight. Being overweight and obese increases cancer risk. Being safe in the sun. Sleeping 7 to 9 hours per night and exercising 150 minutes per week, get routine screenings, and promoting vaccinations. And unfortunately, we know that these risk factors are bad, and we also know that many people have more than one risk factor. So unfortunately, tobacco and alcohol combined, that's a 30% risk. Poor diet, another 15%. You can add the risk increases 15% by every single risk factor. And 75% of oral and oropharyngeal cancers are caused by our lifestyle. Even before EVALI was out in our new term on how we describe vaping, lung-related illnesses, I've been talking about vaping for a couple of years. We've known for years that it's bad. Any tobacco use puts you at a higher risk of oral cancer. Hookah, vaping, e-cigarettes, traditional cigarettes, chewing, pipe smoking, marijuana, that's all kind of in the same category. And we know we're very concerned now because vaping is an epidemic in all U.S. high schools. For instance, one Juul pod or one vaping pod contains the same amount of nicotine as a whole entire pack of cigarettes, about 20 cigarettes. The smoke inhaled in a typical 1-hour hookah session can equal the same amount as 100 cigarettes. If you're looking for some really great research on vaping, maybe I could come back and do a webinar on that as well. There's a really great article that was released in January of 2018. So again, well before people were hospitalized and dying. This reviewed 800 different peer-reviewed scientific studies. And overwhelmingly, all of the evidence is that vaping, e-cigarettes are very, very bad for our health. The nicotine exposure is very similar to traditional cigarettes. The exposure to toxic chemicals is very harmful. The tendency towards dependence and abuse may lead youth to smoking traditional cigarettes. Secondhand exposure to vaping is still very harmful. Increased risk of injuries and poisoning. E-liquids can be fatal. Evidence that it contributes to wheezing, coughing, and asthma flare-ups. And this is the big one on the bottom. Early research shows biomarkers that may increase oral cancer risk. Being overweight or obese is also a risk factor for many, especially for esophageal cancer. And unfortunately, this is very sad. 25% of cases that have been diagnosed had no risk factors whatsoever. And that's where you can do a little deeper dive, and we've been able to determine that maybe about 10% of oral cancer cases are genetic. The Healthy People objectives encourage the reduction of tobacco and alcohol, a healthy diet, and an increased access to health care, with a goal that half the population over the age of 50 will receive oral, skin, and rectal examinations every year. It is a standard of care for dentists, dental hygienists, and dental therapists to provide intraoral and extraoral visual and tactile examinations. This includes inside and outside the mouth, under the jaw, behind the ear, and down the neck, all the way to the clavicle. Looking with our eyes and feeling with our hands to check for lumps and bumps that cannot be seen. It's super fast, it's free, it's non-invasive, and should be the part of every dental examination. It is well documented that many dental professionals will skip the tactile examination. However, palpating under the jaw and down the throat and checking swallowing are key for detecting oropharyngeal cancers and the most high-risk sites. It is advised that dental professionals do at least annually. That is the professional recommendation, but even better at every visit. And it's important to encourage the public to ask their dental professionals to provide this service if they're not receiving it. There has been a movement on YouTube asking dental professionals to step up to the plate, and even celebrities are encouraging more screenings after their own personal battles with cancer, like Michael Douglas. Palpating may detect tumors, but also may detect lymph node involvement in high-risk sites. There's a very large chain of lymph nodes in the head and neck. During the extraoral exam, dental professionals are well trained to also check for abnormalities on the face, the scalp, the hands, and the neck, and commonly referred to other medical professionals during the screening process. And finally, documentation is super important of risk factors, screening process, education, and referrals. They're pretty critical for the continuity of care. Many dental software programs allow for this, but there's also templates like this one that you can download and print off to clearly document what you see and feel and what you've talked about. This is really exciting. On October 1st, the American Dental Association just expanded their policy on oral cancer detection to include oropharyngeal cancer. They recommend routine visual and tactile examination for all patients, not just high risk. And this aligns with their policy from last October to support the use of administering the HPV vaccination inside the dental office. Recent data is showing that only 1 out of every 3 adults have had routine screenings. There's big disparities among minorities, low income, uninsured, and less educated. So every patient should be screened at least on an annual basis by a dentist, dental therapist, or a dental hygienist. So the self-examination, this is new for most dental professionals. We just started talking about this, encouraging our patients to take a proactive role in screening at home. It's recommended that once a month, patients go into the mirror and look at their face, look at their neck, and feel all of the tissues. This should be encouraged to be done in conjunction with professional screening. How we want to encourage our patients to do this self-exam is they want to remove any appliances that they might have inside their mouth, look and feel inside the lips, look at the gums, pull the cheeks back, tilt the head back, look at the floor of the mouth, look at the roof of the mouth, pull the tongue out really, really far. You have to look at all surfaces because remember, way in the back is the high-risk spot. Use the fingertips with light but firm pressure to feel for any lumps or bumps in the lips, cheeks, tongue, under the chin, and along the neck. And look for changes, sore throat, hoarse voice, clearing the throat often, or just thinking that something isn't healing like it should. Outside of the mouth, it's important to palpate all those same structures in front of the ear, in back of the ear, back towards the scalp, down the whole side of the neck, underneath the chin, and all the way down to the clavicle. This throat scope is a really awesome tool that I like to use inside the dental office, but you can also encourage patients to use it at home. We know we can't see things if it's really dark in there, so this is a lighted tongue depressor that allows you to get the tongue out of the way to see the throat better. and of course offers this great light. And it's actually very, very reasonable. It's only $20 for a starter kit. The handle here has the light on it. That's reusable. The tongue depressor is disposable. It just pops off, and it's about 30 cents for each tongue depressor. There's also some really other cool things on Amazon. The oral light is another one. And then this endoscope on the right side, I actually just ordered it. I haven't received it yet, but it's a tiny little, I guess, camera that you can hook up to your phone or to your laptop. So you can look inside your ear. They have a picture here of looking down the back of the throat, the skin, and even monitoring, I guess, your teeth. So what else is new besides promoting dental professionals, screening all of our patients, asking about risk factors, promoting self-monthly exams at home? The shift really now has been on cancer prevention and implementing the HPV vaccine in the form of making a strong recommendation and even the administration of the vaccine in the dental office. HPV vaccination is now considered an oral cancer prevention tool. We know that HPV virus is the most commonly sexually transmitted disease in the United States. 8 out of every 10 people, almost every single one of us, have probably been exposed. There's over 200 different strains, and most of them will not cause cancer. However, we know that there are a handful that are directly related to cancer, specifically HPV-16 for oropharyngeal cancers. HPV can lead to cancer in both males and females. Nearly all Americans are going to develop some sort of an HPV infection at some point in their life. 99% of the time it clears the body, but that 1% that it lies dormant may come back and actually lead to cancer. It is transmitted through vaginal and oral sex and skin-to-skin contact. Our highest exposure is typically in our teens and early 20s, and most people will never know they had an exposure, and it clears your body. One of the major reasons that dental offices is a great place for HPV vaccination is that it's intended to treat adolescent populations. And many adolescent populations do not have a primary care provider. In fact, less than 50% receive preventive care and have no primary care provider. So the dental professional may be the only health care provider that they have. For 9 to 14-year-olds, it's recommended to have 2 doses 6 months apart. That's the average age, or that's the average time in between what's recommended for dental cleaning. 15 to 26-year-olds typically require 3 doses. The first 2 doses are a month apart, and then the 3rd dose again could be given at that 6-month cleaning appointment. If the immune system is suppressed, then 3 doses may be recommended. And there is a pretty complex chart that if somebody gets off track or they go too long in between doses, there's a pretty great chart that providers have that help guide how many injections they might need and how far apart. And actually, the vaccination can be even given up to age 45, although it's not considered as beneficial when people have had maybe multiple exposures. So that, again, might depend on lifestyle. Can't emphasize this enough. The role of the dental office in HPV vaccination is to educate about the gap year. We might have our exposure in our teens or 20s, and then we might go 20, 30, or 40 years later before it manifests itself with oropharyngeal cancer. Again, most of the time there is going to be no warning signs before the cancer appears. Vaccination can prevent more than 90% of oropharyngeal cancers, and vaccination is extremely effective at preventing the types of HPV that cause oropharyngeal cancers like HPV 16 and 18. And this is proof that public health efforts are working. There's been a 71% decrease in HPV rates among teen girls since implementation in 2006. Nevada did pass legislation back in 2007 that requires insurance companies to pay for vaccinations, HPV vaccinations. And in Washington, D.C. and a couple other states, it's a legal requirement for 7th graders to have the vaccination before entering middle school. In today's political climate, it's pretty imperative for dental professionals to consider the overarching goal of health promotion and disease prevention, including vaccinations and vaccine safety. With over 80 million doses in 129 countries, over 5 agencies around the globe monitoring vaccinations, the HPV vaccination is very safe. There is no evidence that it causes autism. It does not cause Guillain-Barré syndrome or POTS, which is a rapid increase in heart rate and blood pressure. It does not cause chronic fatigue syndrome, and it does not cause death. Well, out of the 80 million doses, 51 deaths were reported, and no evidence was found to link to the vaccine. No timelines, no patterns, no medical findings. The reports have stated that there is no evidence to even prove a causal relationship. So we can promote the vaccine, we can talk about risk factors, we can educate our patients of how we can prevent cancer, and we can assure them that the vaccine is very safe. So how can we do this in the dental office? We can incorporate it into our medical history. Have you had your HPV vaccination? Do you get routine vaccinations? Do you vaccinate your child? Are you aware that there is a vaccine that can prevent mouth and throat cancer? We can incorporate it into our oral cancer screening. We can incorporate it into all health screenings and health fairs. And we can give facts and data in just very simple, relatable terms. Some of the things I love to say when I'm talking to patients is, oh my gosh, did you know 75% of cancers in the mouth and throat can be prevented? Or, oh my gosh, I just went to this great class, or I just, read this really great article that came out. And so we can tell our patients that we are learning about all these new things at the same time that they are. The adjuncts that I talked about, salivary samples, looking with a special light at the tissues, these are adjuncts that help open the conversation about oral cancer and can very easily embed messages about vaccinations as well. So we can assure our patients that the vaccine is very safe and that their healthcare providers can answer questions for them. HPV vaccination can prevent cancer, up to 6 types of cancers with a simple shot. 80 million doses have been administered, and vaccine safety is highly proven. The most common adverse reaction is fainting, and that's only about 6% of the time. So new protocol has been implemented that once somebody receives the HPV vaccination, they must sit for 15 minutes before they get up to minimize the fainting risk. So many myths and misinformation exist around vaccine safety. We want to make a strong recommendation and do not transfer your own personal beliefs to the patient. As opioid addiction, vaping, and oral cancers rise, oral health is of the utmost importance. Dr. Ricks, the U.S. Assistant General Surgeon, now says that dentists have the obligation to inform patients on vaccines. The 2020 Surgeon General's report is now going to include oral health on its own and as a byproduct of substance misuse, economic prosperity, and vaccinations. So we now have the Surgeon General saying it's no longer optional. Dentists should absolutely be talking about vaccinations in the dental office. Vaccine hesitancy may be driven by social and political agendas. Many stakeholders can influence perceptions on vaccine safety. It's important to stick to the principles of facts, the credibility of the source of the information, and use consistent, clear, and respectful messaging. Some really great resources for our patients and for dental providers. Probably my favorite one comes from the American Academy of Pediatrics. They have 2 fact sheets that specifically talk about HPV vaccinations specifically for dental professionals. This one here says that oropharyngeal cancer is squamous cell carcinoma of the base of the tongue, the pharynx, and the tonsils. It's rapidly increasing. It's hard to detect. It spreads fast. 8 out of 10 people, almost every single person is going to have an HPV infection at some point in their life. And that dental professionals can play a key role in cancer prevention. This is the second fact sheet that says we want to make a strong recommendation for the vaccine, be ready to answer questions. The HPV vaccine is important for prevention. That's why the age is so young, because we want children to be vaccinated before they ever have an exposure. Vaccination can still occur after an exposure, but by far it is the most successful before exposure happens. The HPV vaccination is effective for warts, throat warts, precancerous cervical lesions, as well as oral cancer, and it is very safe. These are some other great resources: the American Dental Association, the Oral Cancer Foundation, mouthcancer.org, There's a 1-800 number, a cancer helpline that will help with transportation, treatment, and lodging for patients who are diagnosed with oral cancer. There's also some tremendous YouTube videos here. So we are providing a handout for you guys. I encourage you to go and look at some of these YouTube videos. And then probably one of my favorite ones is the 6stepscreening.org. And this is really about empowering your patients in doing that self-assessment at home. Dental Practice Solutions has a really great article from April of 2018, 5 simple steps to implement an oral cancer protocol into the dental office. And then, of course, we have this fabulous resource here in Nevada, Oral Health Nevada, really fabulous website with statistics and resources as well. And then, of course, you have the immunization gurus. Anything you could possibly want to know about disease prevention and vaccinations, please reach out to Immunize Nevada and the High Sierra AHEC. They've just been phenomenal to work with and have a wealth of information. So we really want to know that all healthcare providers need to play a bigger and better role in cancer prevention. We want to implement protocols to assist in education and early diagnosis. We want to educate and document. We need to know what our patients' risk factors are, so we have to ask them about them. Continually to monitor and evaluate high-risk sites, make appropriate diagnosis and referrals, and take a leadership role in ensuring patients get routine screenings. You can develop an office protocol. Who is responsible for the screening? When will they be done? How will you ensure consistency? What devices or tools will you be using? What will be the norm and what will be kind of the add-on or the adjunct? Have your entire dental team educated on vaccine safety and effectiveness, and provide dialogue for sequencing of vaccinations and completions. April is Oral Cancer Awareness Month, so this is a great time to really bump up your office kind of protocols. Raise awareness, do social media campaigns, provide screenings, maybe free oral cancer screenings in your office. Contact the media and talk to them about the stats, the things that we know that are new about oral cancer. Invest in adjuncts and have flyers or brochures that your patients can take home with them. Wouldn't it be awesome if we could have an oral cancer van that went around our whole entire state? It could talk about oral cancer, that could actually provide screenings and vaccinations. We know that, outreach like these NAMA vans are simple. They're opportunistic screenings. They're easy. And we know that they are able to reduce death rates by promoting early discovery. Unfortunately, there's lots of cancers. We want to end them all. I just wanted to point out here, if you're looking for what the ribbon for oral cancer or head and neck cancer is actually maroon and ivory. And I have absolutely loved being a dental hygienist. I've been a dental hygienist for 25 years, and I think it's a really great time to be in healthcare, knowing what we know now, knowing that we have a cancer prevention tool, knowing that the medical and dental community can now work together more efficiently to better serve our patients. Hopefully, maybe 10 years from now, if I was giving this presentation, we could have a lot better statistics than what we have now. So I do think we have maybe about 5 or 7 minutes where we can go through and answer questions that you guys have. And thank you so much for your time. We've provided a handout for you, and this is my email, and you can reach out to me anytime, and I'd be happy to help. I'm just going to look at a couple questions here. Do you know where Nevada is with relation to making progress towards allowing dentists to vaccinate? I don't know specifically as far as dentists, although the American Dental Association represents all dentists in the United States. And they have very, very strong policy, 2017, 2018, 2019, promoting vaccinations being given in the dental office by the dentist. I can tell you that the Nevada Dental Hygienists Association just this past weekend passed a policy to support dental hygienists to be able to administer vaccinations. So I do anticipate over the next 2 years for the Nevada Dental Hygienists Association to be pursuing that, and hopefully that would be a collaborative effort. Maybe we could get the Dental Association and Dental Hygiene Association together on board for that. But I know both groups on the national level, and I know the dental hygienists in Nevada are both looking for us to play a bigger role in cancer prevention. And then the other question I have here is, how would you encourage someone to perform self-exams and what should someone be looking for. So I think it's much easier if you're talking to a woman. Most women do perform monthly self-breast exams at home, so they could very easily combine it with that. But I usually just pick a time, first of the month, middle of the month, end of the month, just to smile, look in the mirror, be grateful that you're living a good life, and just make sure that you're looking for changes. It's kind of like patients have been educated to do that for breast cancer. They've been educated to do that for skin cancer. And I think it's a very good, easy way is just to throw it in and lump it in with just overall general health. We should be looking at our skin for changes with mold. We should be looking at our mouth. We should absolutely be feeling the throat if they did nothing else, just a nice kind of quick palpation on the sides. If they can turn their head to the side and palpate down, and then look straight ahead and kind of grab the throat and swallow. That's a lot of times when you can catch a lump or a bump too during swallowing. So I think for women, it's easy. Incorporate it with your breast exam. For just the general population, just encourage overall health and wellness, looking at your skin, looking at changes with your appetite, your weight. I think we could all probably do a little better job in assessing our overall health. Are there any other questions? Thank you for those two.
Yes, Lanza, I'm seeing a couple down here. It says, are oral cancer screenings usually covered by dental insurance, or is that an extra cost for the patient?
That's a great question. It is built into the examination. There is no extra cost. There's no diagnostic code or billing process for the oral cancer examination. It is part of a routine assessment done by the dental hygienist, and it is also done as part of a routine examination by the dentist. No extra fee, no extra cost.
Perfect. And I see another question came in as well, and this is a great one, and we can speak to this as well, but why aren't more dentists and physicians, for that matter, recommending HPV vaccination to their young patients?
Oh, that's a really good question. I just read a research article that was published yesterday that talks about this, that if you didn't receive it in your base education, it's very hard to add it on later on. So, this is research and science that's just coming out these last couple of years. So, for me, I've been practicing for 25 years. We were not talking about this when I went to school. So it's just out of our comfort zone because we haven't been taught it. We haven't been able to role play and practice it. Just now in the last year or two, our continuing education course is coming out. So I think it's just change, right? It's not something that we're used to doing. We haven't been trained. We've all been trained to do a screening, but honestly, even that studies show we're not doing great. I think that it's like any other healthcare provider too. We have lots to do in our appointments. We have very little amount of time. It's not a billable or reimbursable procedure, right? So we don't make money off of it. I mean, I hate to say that, but there's quite a few reasons why I think there's been a lull. And we're hoping that with webinars like this, we can talk about how serious of an issue it is, that we can get out of our comfort zone and incorporate, some new techniques and new dialogue. And I'm hoping more courses like this will be offered so people feel more comfortable doing it.
Absolutely. And I'll kind of wrap this up with one last question just because we're running out of time. There's lots of good questions today, fortunately. Would the HPV vaccine be paid for by health insurance or through dental insurance if it was administered by a dentist?
It would be under medical insurance. And the dental office actually offers quite a few things that can be billed under medical insurance. So most dental offices are very familiar with cross-coding between medical and dental.
Perfect. That's great to know. Okay, well, we'll go ahead and with that, just wrap up with a few housekeeping items. If you are requesting nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey, which will pop up on your screen when the webinar is ended, or in a post-webinar email. And the email will be sent out by the end of today, and all CEUs will be emailed out within the next week. And if you'd like to view or share this webinar or the slides for that matter, we did have a question regarding that because there's so many great resources that were included in this presentation. The recording and those slides will be available on the Immunize Nevada website along with information for future webinars. It typically takes us about a week to get those up, so just be patient with us while we work to get our website uploaded or updated, excuse me. I would just like to then thank Lancet for today's NILE webinar. We appreciate your wealth of expertise. And of course, thank you to all of those who participated. If we were not able to address your question in the live session today, we will go ahead and forward those on to Lancet so that she can answer those after the webinar is concluded. Thank you so much and have a great day.
Thank you, guys.